What is the portal hypertension? Portal hypertension is a elevated pressure in your portal venous system. Means the pressure increased in the portal venous system, and the increased pressure can lead to splanchnic vasodilation, then the collateral blood flow through the portal systematic anastomosis and increase the hydrostatic pressure. The normal pressure of 5 to 15 cm H2O in the portal vein is consistently exceeded about 25 cm H2O. Causes are classified in accordance with the main site of obstruction to blood flow in the portal venous system. Then what are the causes? The first one we are seeing prehepatic pre-sinusoidal. Portal vein thrombosis due to sepsis, umbilical portal pyemia or procoagulopathy or secondary to cirrhosis. Then the abdominal trauma including surgery. Other prehepatic causes is a portal vein thrombosis, splenic vein thrombosis, massive splenomegaly, splanchnic arteriovenous fistula. The next one is a hepatic causes. Hepatic cause is a three types: pre-sinusoidal, sinusoidal, and post-sinusoidal. Intrahepatic or pre-sinusoidal schistosomiasis, congenital hepatic fibrosis, drug, vinyl chloride sarcoidosis. Then the sinusoidal cirrhosis, polycystic liver disease, nodular regenerative hyperplasia, metastatic malignant disease. Then third one intrahepatic and post-sinusoidal is a veno-occlusive disease. Last one is a post-hepatic and post-sinusoidal. It has a two types, cardiac and non-cardiac. Cardiac causes is right-sided heart failure, severe tricuspid regurgitation, constrictive pericarditis, restrictive cardiomyopathy. Then non-cardiac causes is Budd-Chiari syndrome. Extrahepatic portal vein obstruction is the usual source of portal hypertension in childhood and adolescence, while cirrhosis causes at least 90% of cases of portal hypertension in adults in developed countries. Schistosomiasis is the most common cause of portal hypertension worldwide, but it's infrequent outside endemic areas. Then, what are the clinical features of portal hypertension? All of the clinical features result principally from portal venous congestion and collateral vessel formation. The first one is a splenomegaly. Splenomegaly is a cardinal finding. Splenomegaly means enlarged spleen. It is the first one important features of the portal hypertension. Collateral vessel may be visible on the anterior abdominal wall and occasionally several radiate from the umbilical to form a caput medusa. What is the meaning of caput medusa? Caput medusa is the name for a cluster of swollen veins in your abdomen. The swelling usually appears around the belly button and the veins branch out from a central point. They are typically painless, but they are a symptom of circulatory problem that are often related to liver disease. The most important collateral vessel formation occurs in the esophagus and the stomach, and these can be a sources of severe bleeding. Variceal bleeding, which commonly arises from the esophageal varices located within 3 to 5 cm of the gastroesophageal junction or from the gastric varices. Drugs capable of causing mucosal erosion such as salicylate and NSAIDs can also precipitate bleeding. Fetal hepaticus result from portosystematic shunting of the blood which allow mercaptans to pass directly to the lung. The size of varices, endoscopic variceal features such as a red spot and strips, high portal pressure and liver failure are all general factors that predispose to bleeding. Variceal bleeding is often severe and recurrent if preventative treatment is not given. Clinical features: patients with cirrhosis frequently develop anorexia, generalized malaise, and weight loss. Clinical manifestations include hepatosplenomegaly, ascites, jaundice, and spider nevi, slurring of speech, a flapping tremor or dysarthria may point to encephalopathy, and these may be precipitated or intensified by the accumulation of blood in the gastrointestinal tract. Portal venous pressure measurements are rarely needed for clinical assessment or routine management, but can be used to confirm portal hypertension and to differentiate sinusoidal and pre-sinusoidal form. Pressure measurements are made by using balloon catheter inserted using the transjugular route, where the intravena cava into a hepatic vein and then hepatic venule to measure the wedge hepatic venous pressure. This is an indirect measurement of portal vein pressure. The most useful investigation is a endoscopic to determine whether gastroesophageal varices are present. Once the diagnosis of cirrhosis is made, endoscopy should be performed to screen for esophageal varices and repeated every 2 years. Thrombocytopenia is a common due to hypersplenism. Leukopenia occurs occasionally, but anemia is a seldom attributed directly to hypersplenism. If anemia is found, or sources of bleeding should be shown. CT and MRI angiography can identify the extent of portal vein clot and are used to identify hepatic vein patency. As a result of gradual chronic occlusion of the portal venous system, then collateral pathway develop between the portal and systematic venous circulation. And portosystemic shunting occurs at a three principal sites. The most important is the development of varices in the submucosal plexus of the vein, in the lower esophagus and gastric fundus. Esophageal varices may rupture to cause acute massive gastrointestinal bleeding in about 40% of patients with cirrhosis. The initial episode of the variceal hemorrhage is a fatal in about one third of the patient, and recurrent hemorrhage is a common. Bleeding from retroperitoneal and periumbilical collaterals, caput medusa, is a troublesome during abdominal surgery, and collaterals may develop and cause bleeding at the site of the stomas. Acute variceal bleeding. Patients presenting with acute upper gastrointestinal bleeding are examined for evidence of the chronic liver disease. The key investigation during an episode of active bleeding is an endoscopy. This allows the detection of varices and define whether they are or have been the site of bleeding. It is important to remember the peptic ulcer and gastritis are common complaints that occurs in 20% of patients with varices.